Hereby open this academic ceremony in which Anneke Terneusen will defend her academic thesis, Know THYSELF, Theoretical and Neurobehavioral Perspectives and Self-Awareness. May I invite you to present a summary of your study and the conclusions of your thesis?
Thank you, Pro-Rector. Dear members of the opposition, dear family, friends and colleagues, thank you for being here today, either in person or online. In the next 15 minutes, I'll go through the research I've been working on during my PhD, which is also in my dissertation called Know THYSELF, Theoretical and Neurobehavioral Perspectives on Self-Awareness. The topic of my PhD was acquired brain injury. And acquired brain injury is injury to the brain that happens after you're born some point in your life. This can happen to anyone, for example, by hitting your head in a traffic accident or getting a bleeding inside your brain. And this damage happens suddenly and usually does not get worse over time, but it can have a lot of different consequences. And some are easy to see on the outside, such as difficulty moving, but some are not as easy to see on the outside, such as problems with memory, emotions, or one of the many other brain functions. In the Netherlands alone, around 650,000 people live with acquired brain injury and suffer these consequences every single day. Luckily, we have good hospitals and rehabilitation care facilities where they can go to recover and learn to deal with their problems. However, unfortunately, for some people, this rehabilitation process does not always go as smooth as we would like. And therapists say that one of the biggest hurdles here is impaired self-awareness. With impaired self-awareness, we mean that people do not see how they changed because of their brain injury. They don't understand how the brain injury affects themselves or the people around them. And about up to 77% of people with acquired brain injury have impaired self-awareness. And this range is this big because it really depends on how and when the self-awareness is measured. People with impaired self-awareness after brain injury have less motivation for treatment. It's more difficult for them to stick to the treatment and they often drop out. And this makes it difficult for them to reach their rehabilitation goals. And this goes along with a lot of frustration for both the patient but also the caregivers. On the long term, it's more difficult for them to go back home and live independently. It's more difficult for them to go back to work, but also to join social activities again. So in general, they have more difficulty reintegrating into the community, and this also puts a lot of stress on loved ones. And this shows that impaired self-awareness is not just a problem in the rehabilitation setting, but also at home and in society. Now, while the problem seems very clear, it's very difficult to pinpoint the problem. So the aim of my PhD was to get a better understanding of the problem so that we know how to move forward and how to treat these people. So we looked at how to measure self-awareness, how self-awareness is related to the brain, and how to treat impaired self-awareness after acquired brain injury. One thing that is clear is that self-awareness is not just something that is impaired after a brain injury, but it's a skill or an ability that we all have and that we are all doing all the time. We are always monitoring our behavior and seeing whether it matches with what we want to do. And this is why we not only investigated people with brain injury, but also people without brain injury. Now, self-awareness is a very broad concept. It means knowing yourself, understanding your strengths and weaknesses, and it covers all areas of functioning, such as the ones mentioned on the board. And one of these areas is cognition. And with cognition, we mean all the brain functions, such as memory, attention, decision-making, planning. And self-awareness of cognition is also called metacognition. And self-awareness can be divided into different elements, and I'll go through them using an example, which is my cooking skills. The first split we can make is offline and online self-awareness. Offline self-awareness is when you're thinking about a skill when you're not actively doing it. So when I'm standing here thinking about my cooking skills, this would be offline. This is sort of a database. It's also called metacognitive knowledge, and it's knowledge and beliefs of your ability to do something. For example, I know and believe that I can make pancakes. Online awareness is when you are actively doing the task, and this can be further divided into monitoring and self-regulation. With monitoring, we mean keeping an eye on how things are going And with self-regulation, we mean changing your behavior when that's necessary. Monitoring can be done during, before, and after the task. For example, before I start cooking, I have the recipe, I have the ingredients, and I can think, yes, I'm able to do this. During cooking, I might smell something is burnt and have to admit that I made a mistake. And after cooking, I can evaluate and reflect, taste the food, see whether it is what I wanted it to be. In chapter 2, we looked at how these different elements are related to each other. More specifically, we looked at how monitoring during the task is related to other elements of online metacognition and offline metacognition. And in a group of people without brain injury, we let them do a memory task, and which we adapted so that we could measure all these different elements. And we found that monitoring during a task is related to other elements of online metacognition, but not to the offline elements. And this is in line with previous research, and this is important because this means that we cannot use an offline element to say something about an online element, and the other way around. In chapter 3 and 4, we took a look inside the brain. In chapter 3, we looked at people without a brain injury, and we let them do a metacognitive task in an MRI scanner, and we looked at what happens in the brain when metacognition goes wrong. In chapter 4, we looked at people with brain injury, and we didn't do our own MRI study, but we gathered what studies are out there and we summarized this. Now, overall, we saw that offline self-awareness is related to areas in the front of the brain, and these are famous for decision-making and planning. The element of monitoring was related to the so-called default mode network. This is a region of brain areas that is usually not active when we are doing something, but it is active when we are daydreaming or thinking about ourselves. And self-regulation seemed to be related to the so-called salience network. This is a network of brain areas that alarms us that something is going on, that signals something in the surrounding is happening and we might have to change our behavior. So overall, we didn't find a self-awareness brain area or network, but we do find suggestions that the different elements have different pathways in the brain. Now, all these different elements can be impaired. People can have difficulties with all the separate elements. The next question is, why do they have problems with this? There are different mechanisms that can lead to difficulties, and we looked at two of them. One is a psychological reaction, denial, in which people are ignoring what is happening around them. These people come across very tense and anxious, and they make up a lot of excuses why they are making mistakes. On the other hand, people can also have a disruption in brain networks that are necessary for self-awareness. And in this case, people are seem more confused. They don't really come up with excuses for their mistakes, but they seem frustrated that things are not going the way they would like, or that they are not allowed to do things, and they don't understand why. In chapter 5, we looked at an instrument that tries to distinguish these two types. We interviewed patients at home and their significant others. We let them fill out some questionnaires, and they did some tasks. And then the researcher observed the behavior, the outcome of the questionnaires and the tasks, and then filled in this questionnaire. And we saw that indeed one part of the questionnaire really relates to the psychological response. Another part of the questionnaire really relates to the disrupted brain functioning. And this is relevant because then you can use this in the clinic when you want to give treatments. The ultimate goal of my PhD was to improve rehabilitation. So maybe the biggest achievement, or at least the biggest study in my PhD, was this one, in which we investigated a new treatment, Socratic guided feedback. And we developed this treatment in collaboration with clinicians at Adelante and our research team. And in short, it consists of 3 elements. The first one is psychoeducation, and this means that the patients are really educated about what the brain is, what the functions are, what brain damage is, but also what self-awareness is and why this is relevant. They practice tasks that are difficult but not too challenging, and they have to be really relevant to the personal goals of that person. And during these tasks, they would get Socratic feedback, which is also the third element, the Socratic guided feedback. And this is more of an attitude than it is a trick or a checklist to go through. And the idea is that the therapist is really open asks guiding questions, and really avoids confrontation. So this way, you really stimulate the patient to self-reflect on their behavior, and you create a safe space in which maybe at some point they will have room to admit that things have changed, that things are going wrong, and that they can do something about this. And then together you find the motives of the patient and then use this throughout the treatment. In chapter 6, we describe the study in which we investigated this. In 5 rehabilitation centers throughout the Netherlands and Belgium, we looked at whether this new treatment works better than the treatment they were already offering. And we mainly looked at self-awareness, because that was our main interest, but we also took a look at these other important rehabilitation outcomes, such as motivation, mood, and quality of life. Now, there's a lot to say about this, but not a lot of time. So in short, we found that the treatments were equally good. This means that the Socratic guided feedback is a good alternative treatment to the treatments already out there, but it's not better at improving self-awareness, which is what we expected. We expected it to be better at improving self-awareness. And there could be multiple reasons for this, and I'll go through a few points. Firstly, we measured self-awareness more on the offline elements. And as we saw before, this doesn't necessarily say anything about the online elements. So it could be that this treatment has effects on the online elements, but we did not measure this directly. Another point is that maybe the treatment has effects later in time. In our study, we followed up people up to 1 year after they started the study. But at this point, they haven't completely reintegrated back into the community. So maybe they need more time to really run into problems and self-discover the limits of their recovery. And the third point is that maybe the treatment was not given intensely enough. Maybe a few sessions during the week is not enough to really make the difference. And we would advocate for offering the treatments all the time around the patient, ideally. This means all the therapists around the patient, but also patients around each other, maybe in group therapy settings where they can learn from each other, and importantly, also the social environment around the patient. And this can have 2 benefits. The first one is that the patient will be triggered to do this reflection in different contexts and all the time, which will make it easier to learn this and make it more automatic. And secondly, this offers the people around the patient a bit more structure on how to approach the patient, which could make them feel more confident and reduce the tension that's between them, which could have positive effects on everything. But these are all things that we still need to study in future studies. So in conclusion, self-awareness is a very broad concept. We divided it into multiple elements, which can be measured in different ways, and this makes it easier to pinpoint the problem. These different elements can be impaired through different mechanisms, for example, through a psychological reaction, but also through disrupted brain networks. We took a look inside the brain and saw suggestions that these different elements also have different pathways in the brain. And finally, we investigated a new treatment, Socratic guided feedback, and we saw that it's a good alternative treatment to what's already out there, and additional effects may still be hidden. Thank you for your attention, and I would like to now give the word back to the prorector.
Thank you very much for the clear presentation. The session will now be opened by Professor Kotz, who was the chair of the reading committee. And Professor Kotz is a professor in neuropsychology and translational cognitive neuroscience, working at Maastricht University.
Thank you, Prorector. Dear candidate and dear supervisory team, it was a pleasure to read this thesis, and it really shows that you've taken on a big challenge to understand such intense topics, and on top of it in the context of clinical work. I really want to congratulate you for that. I'm particularly curious about self-awareness in the brain, and consequently I have focused on chapter 3. And I have a principal basic question that relates to your behavioral results in the first place, and then how they relate to your brain activity patterns that you reported. So on the one hand, you used a self-awareness scale, which is something very subjective, and people actually gave very high confidence ratings on this particular scale. But when we now look at the accuracy data in your brain study, it seems relative to these very confident judgments on their self-awareness, it comes out rather minimal. So I'd like to understand how you see the relationship of these self-awareness scales and their value as predictors of what people then actually do. That's my first question.
Highly esteemed opponents, thank you for the compliments. If I understand correctly, you are referring to the questionnaire and the task we did.
Yeah.
Yes, I think with the questionnaire, indeed, the main issue is the subjectivity of it. And people can be very confident, but this doesn't mean that they are actually also behaving this way. That's why we also did a task in which we actually checked whether they were actually accurate in their answers and not only the confidence ratings. But how this could be related to each other as a predictor, I think it might show maybe people will be biased towards giving high ratings or low ratings, and then you could already see this in the questionnaire. However, with the questionnaire, you never know the actual truth, which I think is always an issue with the self-awareness measures.
Right. Of course, you prompt them with a very particular task. You use a memory task. In what way do you think one could go beyond with different types of tasks? Would you think it's necessary to actually explore cognition, broadly speaking, in a much broader way to understand how these subjective measures could play out?
Yes, definitely. I think each type of task also, you can have different self-awareness for different behaviors. So people can be very self-aware of their memory skills, but not of their abstract reasoning skills, for example. And it can change per domain of functioning. So yeah, it can differ. So it would be good to investigate different domains to see whether there is an ultimate self-awareness measure.
Right, because the term cognition as such is a broad term, right?
Yeah.
So we need to explore that obviously a little bit further. I'm curious about the analysis approach that you've taken. So you very nicely explored the different types of networks that may be involved in this, but then you choose a very specific ROI analysis. I assume that a whole brain analysis didn't deliver appropriate results, or did you actually choose the ROI analysis in a hypothesis-driven way? But then if you look at the results, at least the core contrast ends up being non-significant. So what alternatives would you have to analyze this differently? But let's first start with the approach.
Yes, so it's indeed always a decision. Do you go for whole brain or ROI specific? We thought it would be better to have at least an idea of where you expect things, because whole brain analysis, of course, you might always find something, but it doesn't mean that's really related to what you're measuring. So we thought it was in this case better to have an idea of what we expect. That's why we stick to this, and we also, from the few literature things that are out there, expected here to be the results. Yeah, so we chose to do the ROI analysis.
Right. Did you correct for the answers that were given? Because that may have actually affected your signal-to-noise ratio in the main contrast, comparing accurate versus inaccurate.
Yeah, so we looked at, they did a memory task in which they had to say whether something was in a list or not, and then the answer they gave was accurate or not, and then they had to say how confident they were of this answer. And indeed, we did not only want to look at confidence, because as we discussed before, that doesn't really mean anything about self-awareness. So we first checked whether it was metacognitively accurate or inaccurate. Mm-hmm. And then indeed, because some people might have only accurate or only inaccurate, that's why we decided to have to discard the people that had only too much of one type of answer. So then we chose to have, I think, at least 13 of each type to have at least some kind of contrast, to try to control for that.
Okay, fair enough to approach a result, but indeed, if we think this to the end, it may be important to consider individual variability in this game. Would you have any idea how you could use that in terms of your brain analysis?
I don't think I understand the question.
Well, I mean, there are other types of analysis approaches to studying brain activity than GLMs and Roy analysis, where you can have more flexibility in terms of individual variation.
Yes, there are many other things we could look at. Also, really network connectivity, for example, or yeah, I'm not sure what's.
I was thinking about decoding approaches, for example.
Oh yeah,
where you have a bit more flexibility, but that's perfectly all right. I have one last question, if I may.
Probably not.
Okay. Jonathan, the question is yours.
Okay.
All right, thanks very much.
Thank you very much for the questions. We move on to Professor Spikman, who was also a member of the reading committee. And he is online. She is online. And she is a professor in clinical neuropsychology and neurological disorders at the UMCG.
Thank you, Conrector. Dear candidate, I would also like to start with congratulating you and your supervisors and co-supervisor with your interesting thesis. Self-awareness, and in particular the impairments in this ability that we see in patients, is fascinating. And I think you did a great job in exploring and investigating this in a clinically relevant way. But in doing this, you made some choices, and I would like to discuss with you one of these choices and also explore if you are maybe open to other alternatives. Because in the introduction, you start with defining impaired self-awareness as being unaware of impairments that are obvious to others. So I assume this concerns all kinds of changes. But then you introduce the term metacognition and narrow this down to only self-awareness of the cognitive domain. And I was thinking, and I'm not sure if this is not charcoal English, but is she not throwing out the baby with the bathwater? Because I'm myself convinced, but it may be my bias, that the construct of social cognition might be very relevant here. Because first, being unaware of impairments that are obvious to others implies that you should be able to see that there has been a change, that you're not the same person with the same capacities anymore. And this requires the ability to look at your present self from the perspective of another person, or maybe from the perspective of the person you were formerly, and to compare these two different states in order to notice that there is a difference. So in other words, I think this involves the ability to differentiate self from others. And this, of course, is also a form of theory of mind. And second, in our group, we found in many different studies, I think you actually cited one of them, that impaired self-awareness was related to impaired emotion recognition, which in turn might be an indicator of blunted affect, which might also play a role. So my first question is, do you agree that looking at social cognition would have had added value? And maybe you can elaborate a bit on that.
Highly esteemed opponent, thank you for the compliments and the question. Yes, definitely social cognition also really plays a role. So yes, I agree, to give a short answer.
That's a short answer, yeah.
In the studies that we kind of wanted to break it down to more the core of what is it exactly. That's why we focus on metacognition. Also because other studies, more educational or other neuropsychology, which is not related to brain injury. It's often called metacognition. But indeed, it also means, but also for social cognition, I think you need to know your own cognitive states, which might indeed, I think it's really connected, but social cognition might be more than only seeing yourself from another perspective.
I agree, that's true. But if you look at impaired self-awareness, that also means that you're not able to see that you have changed as a whole person and not only cognitively, I think.
Yes, definitely. Also, the scales that are used in the clinical studies, like the patient competency rating scale, is much broader. That covers also the physical domain and also the social aspect, emotional aspect. So there it's often not only the cognitive part. Yes,
because in addition to that, I looked at chapter 4, and well, with social cognition in mind, you may interpret some of these findings also as a support for my assumption. For instance, you found that involvement of the anterior cingulate cortex in impaired self-awareness was demonstrated, and that's of course a structure that is important for mismatch detection and motivation, and also midline structures which are involved in self-related processes. So do you think that is evidence for taking more the stance that this may be a problem in the field of social cognition?
I agree that also in future studies it will be really interesting, also especially the effects on the environment. You really need to have the social aspects in there as well. Because it's also conflict. Often the problem leads to a social problem because of frustration and conflict. And for that also to process that, you also need social cognition. So I agree that it would be interesting to also take that into account.
Yes, because if you had found evidence for that, would your treatment have been different? Because if you knew that people are not very much capable of taking another stance towards the problems, or they lack the emotional abilities to be motivated to deal with these problems, would it have changed your approach?
It would be interesting to add a specific part also in every part of the psychoeducation, also on the social aspect, so that they can understand that it also affects the partners and not only themselves, but also maybe in the tasks. But this, I think it really depended. It could have been in there. The treatment was really flexible. So if their main problem was interacting with people, then it could have taken a social direction. But it wasn't specifically in there, but it could definitely be helpful. Also, if you want to include more the social environment, which we do think is really relevant, then indeed it would also be important to have a specific social cognition aspect in there.
Well, I think we agree, and I think also that my time is up, but I do not see the conlector, so...
A very short question would be possible. And a short answer.
Maybe you, with a very short answer. Well, if you look back at the patients that were treated with this treatment, do you think it is possible that their main problem might have been in the field of social cognition? That's just curiosity of my side.
For some, yes. Very short.
That's the short answer. Thank you.
Is that sufficient? Yeah, you want to add something, or?
I think not for. I think for some people it might have been the main problem, but for others, clearly, they were so cognitively impaired that social cognition might be too difficult to start with. So maybe then other cognitive aspects are better to first treat before taking the next step of including social cognition.
So,
well,
yeah.
Maybe we'll see each other at another moment.
Okay, thank you very much. And the opposition will be continued by Professor Verbund, who is also a member of the reading committee. And she is working at Maastricht University in Adelante and is professor in rehabilitation medicine.
Thank you. Dear candidates, so first of all, I would like to congratulate you with this beautiful thesis. It's a very important topic. In order to improve healthcare for patients with acquired brain injury, it includes an interesting set of articles, and it's well written. So I would also like to congratulate your PhD team. But of course, I'm very eager to discuss the content of your thesis with you. And that brings me to chapter 6. In this chapter, the RCT is presented, in which you compare the effect of the new treatments, Socratic-guided feedback therapy, with usual care. And as the results show, the main outcome variable, self-awareness, improves in both groups. There didn't appear to be any difference in the change between the groups. So I also noticed in the methods section that the professionals followed a half-day course to learn how to practice the Socratic guided feedback treatment. The cognitive trainer followed the course, and the other team members could join. So first, I would like to ask you, can you provide some details about that half-a-day course?
Highly esteemed opponents, thank you for the compliments and the question. The half-day course was provided by one of the cognitive trainers that was also involved in the development of the treatments. And it consisted of a short presentation and a workbook to go through the steps and how to approach a patient. It was a lot of practicing, like role play on how to then approach the patient. But because they were already cognitive trainers, they could go into that quickly.
But it's a new approach, so is it enough? Is it too restricted to give a change, probably?
In hindsight, maybe yes.
Mm-hmm.
Although after the training, people were confident that they could do it.
They were confident. Self-awareness.
That shows another type of self-awareness. But in hindsight, I think it needs much more training and practicing, and also...
Did they have intervision afterwards? Because in some centers there were only some people included in the trial. So did they continue practicing, for example?
There was no official intervision. I think they did, so they, as they usually would do, discuss a patient and also remind themselves of the approach and how to do this, but there was no official intervention for the study. And they could always connect with the trainer of the protocol, but yes, like I said, no official one.
So if you would have the possibility to redesign the training, how would it be?
Well, ideally, if there's no restrictions, you would have a full multidisciplinary team that only treats the patients in the one group and not the other, but because of practical reasons, that's not always possible. I think it would be a multiple afternoon training, maybe, also not too much, but then with some time in between that you can practice, come back, discuss, see how it went.
So that I went back to their rehabilitation center, practice it, and then give their feedback, for example.
Yeah.
Okay. I also noticed that you, in your discussion section, you reflected on the assumption that the contrast between the two treatments could be too restricted. So I wondered, did you check that? Did you check protocol adherence?
We tried to. Unfortunately, there was not always well registered by the trainers, especially the ones in the experimental group. They had this form that they would fill in and send to us, so then they would be reminded of the protocol, but also tell us how well they think this went. Unfortunately, not everyone did this or could not send this to us. We didn't have one specifically for the control group because, it really differs per person, and you don't want to prompt them with, did you do this today? Because then they would maybe do that too much. The idea was that they would send a summary of what they did in that session to us in the end, but this was also not done very well, so it's difficult to check.
Okay, yeah. And another question about in your discussion section and also in your presentation, you reported about the fact that you want to actually want to include the partner of the patient in your training or in treatment. Can you tell me more about that? What will it be? What would be your idea about that?
Of course, it's always tricky because the partner is not the therapist, so that you need to find a good balance that they don't feel like they are treating the partner, that you get more distance between the partners because they feel like they are treated as a patient by their partner. But it would be good, I think, for them to also really understand what brain injury is, what it does, that this can also be an effect and that it's nothing personal, even just understand what self-awareness is, that they have problems with this and how they can then approach them without getting into a fight every time.
And would you include the partners in a group training, or is it then just a patient and a partner?
Both, ideally. Patient-partner together to see how their interaction is, how that goes, where they can work on, like what their problem is. But also when I presented this research for a group of partners, they really said it would be really helpful for us to also learn from other partners. So then I think that's also really helpful that they share their experiences.
Okay, thank you. I'm happy with your answers, so I want to return the words to the prorector.
Thank you very much. Now we move again online to the next opponent, Professor Evans, who is professor in clinical neuropsychology and works at the University of Glasgow.
Thank you, Prorector. Dear candidate, thank you for the opportunity to read your thesis, which I very much enjoyed. I think all of us who work with people who suffered a brain injury recognize the real importance of the topic that you've addressed. And it's very nice to see how many different ways that you've addressed this topic. So thank you. I'm going to start with a question about chapter 5, where you were investigating the difference between the impaired self-awareness scale and the denial of disability scale. And I was curious about whether there was any examples in your sample of dissociation between patients who maybe score higher on the impaired self-awareness and low on denial of disability and vice versa. So were there any evidence of dissociation which give you some confidence that these scales are differentiating these two areas of difficulty?
Esteemed opponents, thank you for the compliments and the question. Yes, in the interaction with the patient, as I showed in the presentation, it's difficult to pinpoint, but you do feel that something is going on, and you do see that actually people are really shocked and surprised when they make mistakes. That's more the impaired self-awareness scale in this case. And the other type is they come up with excuses. I didn't do this right because, and some are valid excuses, because strange people are in my house, so I didn't sleep well, but sometimes also it's raining outside, so that's why I scored poorly. So this is more really the trying to get away from the topic and come up with other excuses. And also sometimes really feeling shocked and sad about how they are doing.
So are you saying from a clinical perspective, you get that feeling of distinction, but in terms of the scoring on the actual questionnaire, was that didn't quite follow that, is that right?
Yes, because on the denial scale, the scores were especially low because, as we also described, a lot of people that are in denial would not want to talk about this, so would not show up for studies. That's the difficult part of doing this research. So in this case, we saw more impaired self-awareness than the denial.
Yes, and I was curious about on the denial of disability scale, it had a relatively low internal consistency. And so I wondered whether there are particular items that seem to be performing differently on the scale, or actually was that low internal consistency really just because the low variability in the scores?
I think it's low because of the low variability in the scores. There are not many people that showed this denial of disability according to this scale. So that's why I think we cannot really say a lot about the scale in this study group because they just didn't really show a lot of denial.
So, in a sense, is your at the end of that chapter you feel positive still about the potential usefulness of the combined scales in differentiating these two forms of impaired self-awareness? And so I'm just curious about what gives you confidence in that, despite that sort of the denial of disability scale not performing how you hoped.
Yeah, so we're confident about the scale in maybe not in this setting and using it in this way, but maybe more in the acute setting, and it has been shown to work in that setting because denial might also show more in the beginning of after the brain injury. So it could be that it's just not there, and then it might not be as useful to distinguish the two, or because people don't show up, maybe. Well, what was I going to say? Yeah, if you know already that there is a self-awareness problem, but you just want to know which type is more relevant, then it would be useful. Because some of these people might actually not have that much self-awareness problems, and that could be a reason why we don't find the high scores.
But do you think there's a way of combining the sort of clinical judgments that you were talking about when you hear a patient saying things, but then which is different from what they might put on the question, what they might say, or how the questionnaire is scored?
I think the instrument is less useful to just take a group and see how impaired their self-awareness is, but it is useful if you know there is a self-awareness problem, but you want to see what treatment might be most relevant. Is it more psychological treatment or more cognitive training? And in that case, you can use the scale to see which one is more prevalent.
Okay, thank you. If I may, just one last question, which comes back to chapters 2 and 3 and your use of the memory and the reasoning tasks there, the matrix reasoning tasks. I was curious about, in those tasks, the person who makes a response, in a way, is not getting any direct feedback that they've made an error. So what you're using confidence, and so in some of those tasks, somebody may make a response. They think they're correct, so they've got no reason to doubt they're correct, and so may give a confident response even though it's wrong, or they may be unsure and give it wrong. So I'm just wondering about whether those type of tasks are different from tasks where some sort of signal of error is more obvious, and then the person is missing that signal. Do you think there's a distinction there?
I think then you get more. Yeah, so we deliberately did not give the feedback, indeed, because we don't want people. We just want to see how well they can feel it for themselves without getting the feedback. Because also for ecological validity in daily life, you don't always get feedback whether something is correct or not, and it was really about the metacognition, really feeling yourself whether it's correct or not. If you would give the feedback, I think that could be a good way to train metacognition, maybe.
Yeah, I suppose what I'm curious about, so on a matrix reasoning task, if I do a difficult problem, I might say, I think it's this one, I've got it right. So actually, but there's nothing, and if you say, well, have you got it right or not, you actually don't know. Whereas in other situations in everyday life, if you stop somebody and say, oh, was that the right thing to say to that person? You might say, oh, no, it wasn't, when their attention is drawn to it. So they get in a way, the feedback is in the environment. It's just that they're not noticing it. So on a matrix reasoning task, there's no actual feedback to notice because it's whether you've got it right or not.
Yeah, so for this study, we wanted to just get a general idea of their metacognition without influencing it. So if you would only have one trial and already gave feedback then, you'd only really have one trial of how they really feel it. But to make it then more consistent, we wanted to have multiple trials. But indeed, it would also be very interesting to see how they respond to the feedback, whether they improve their metacognition when they get the feedback or when they make mistakes. But I think more in the setting of a training and different goal in the end.
Okay, thanks. I'll hand over.
Okay, thank you very much. The opposition will be continued by Dr. De Kort, who is a retired neurologist at the ETZ hospital.
Thank you, Rector. Dear candidates, in the first place, my congratulations for your interesting thesis, and also congratulations for your supervisors and co-supervisor. It deals with a very interesting subject and frequently encountered in neurological clinic and rehabilitation setting. And indeed, there is no, when there is no or reduced insight in one's own capacities, it's a major obstacle in rehabilitation. And also the title of your dissertation is very interesting, Know Thyself. It's a beautiful one, and as you know, a very old aphorism already at the Temple of Apollo in Delphi. And already in those days, it was not taken for granted that people know themselves. And also nowadays, when you look in the era of me, myself, and I, knowing thyself is of interest to many people. So knowledge of oneself seems to be not available for everyone, even when there is no brain damage. But on page 8 in the introduction, you state that self-awareness is a cognitive function, and this means that unimpaired self-awareness also exists. So that leads to the first question. Do you think that all people without brain damage have unimpaired self-awareness, leading to full knowledge of their own capabilities, strengths, and limitations?
Esteemed opponents, thank you for the compliments and the question. And definitely, no. People don't have perfect self-awareness. Even if people have perfect self-awareness in one domain, it might not be perfect in another domain. And I think it's very natural to have this variability. What we meant to say with that is that it's not only... In the brain injury literature, we also always speak of impaired self-awareness and not of just self-awareness on a scale. For example, it could also be the case that people that run into these problems already had poor self-awareness before they had the brain injury. And then, is it really impaired or is it still the same? So that's why we tried to translate it to self-awareness.
So it may be a too broad definition of the concept, that, because it's strange that you have a cognitive function which has so much variation that also normal people without any brain damage have such a huge variety. As you can see in chapter 2, there you see a lot of variety in the answers of the normal, unimpaired people, even young people. So that makes me ask, why is it that, wouldn't it be better to more subdivide the concept of self-awareness in more parts so that you can address every single subunit with appropriate tests?
That's what we try to do in the different elements. So the online elements really during a task, right before the task, or more thinking about yourself in a future situation or in a situation that has already passed. And then you can do this for every different domain. So for specifically the memory, or specifically abstract reasoning, or physically. So this way you could break it down into very specific.
I don't say that you didn't try to do it, but in my opinion, it might be necessary to subdivide it every more than you did already. That when you look at the poor cognitive component of the self-awareness, that even that could be more subdivided. Don't you think that would be possible?
I'm just thinking how we could subdivide it even more. Of course, it always depends on the underlying function that you are measuring. There's already a large variability in there, so then I think the variability will always stay. I'm not sure how to make it more specific than the different elements per domain.
Yeah, but when you look, for example, at memory or attention, or then you have normal values. And I think that when you look at the tests you performed in cognitional self-awareness, the spread was even more than we see normal in cognitive tests. Or is that not correct? Did I get it wrong?
There is a large spread, yes. Yeah.
Okay. What intrigues me very much is your proposition number 4, and I would like to ask one of the paronyms to cite that proposition.
Paradoxically, if you can measure a patient's impaired self-awareness, the problem of impaired self-awareness does not exist.
Thank you very much. I've read this proposition several times and I still don't get it. So please explain to me.
So theoretically, if you try to measure something that is absent, so that is difficult, you can only measure it indirectly. So either you have a self-awareness scale and people score low, and then you interpret this as impaired self-awareness, or you compare it to another person's opinion. It's always indirect. And practically, this also refers to chapter 5, in which the people with high denial likely do not show up, or people with impaired self-awareness who always feel conflict, or if the partners always feel conflict, they will not sign up to join studies. So, and if that problem would not exist and they would show up, then the thing we are interested in would not be there.
But it's especially important when you look at the self-denial component of self-awareness.
But yes, but also for the other impaired self-awareness. They might not find it relevant, not want to join with the studies. The partner might still get into conflict with this person, so they may not want to join as well.
But is it then more in the context of, as Professor Pickman told us, social capabilities?
Yes, for joining for the studies, yes. This social aspect is huge.
I may ask another question.
Feel free to ask another question.
Yeah. In proposition 5, you mentioned that null findings contribute significantly to our knowledge, and I agree completely. But however, in proposition 3, you state that Socratic feedback should be offered more in rehabilitation care after acute brain injury. And why is that? Because in chapter 6, in my opinion, on the effectiveness of this therapy, in fact, in my opinion, it was a null finding. You could not prove it was better than care as usual, and also the effectiveness of care as usual has been, in my opinion, proved neither, because you, in the discussion you state that the natural course of recovery of impaired self-awareness after acute brain injury without rehabilitation is unknown. So you never know whether care as usual has been better than the natural course.
True. We'll never know this. And why we still think it should be offered is because this, if we would not have anything, this is kind of the problem we started with. People have care as usual. These patients with impaired self-awareness are coming in, but we don't know how to treat them. And now we have at least some kind of structure that they can use, that at least the therapist might feel a bit more confident on how to approach this. And as I also explained, there might be different effects or different reasons why we did not find this. So it would also be interesting to apply it more, that we can study it more, but also to give the structure to the therapist.
Okay, so you agree that there's any evidence for rehabilitation of self-awareness, and that the Socratic feedback therapy is as good or as bad as care as usual. But that means that you are, in fact, a believer. It's not hard science.
It's not a hard science, but indeed I'm a believer of the Socratic feedback treatment. Mm-hmm. Also, in the feedback from the therapists, I think it was also taken very positively to get the half-day training, so at least they also understood a bit more. They had this approach, so also the feedback was positive. So in that case...
Yeah, but you don't do a therapy for the therapists. You do a therapy for the patients.
But if in that case... Well, we didn't find evidence for that, no. But if it would help the therapists feel more comfortable, have less conflict or frustration in the therapy room, in the end it could help the patient as well.
Could also something better in
Could I maybe if it's very brief, otherwise I would like to...
No, it's not very brief.
Then I would...
Thank you very much.
Yeah, thank you for your questions. I would like to proceed to the next opponent, Dr. Duits, who is Associate Professor in Clinical Neuropsychology and working at the University Hospital of Maastricht.
Dear candidates, also congrats to you and your team. And this is really a challenging thesis, a challenging concept. You are perhaps a believer in this treatment, but before this, well, you have this model, you have this theory, your concepts, you need how to measure this. Of course, you can learn from the treatment maybe to change your model. So I was struggling with all these concepts, like you perhaps. We have this awareness, we have coping, we have denial, we have these off and online elements. And if you look back now to this model, where do you think you need to change this model because you started with a theory and now, after all this experience with these measurements, with this treatment, how does this model look like? For instance, where do you put the offline elements, the coping, denial part? Maybe, what are your thoughts?
Esteemed opponents, thank you for the compliments and the question. I would want to make a huge model that includes everything, but of course that's not very practical. So to keep it simple, I would still keep the offline, online elements, the different parts of the online elements as well, and then maybe indeed then add denial and coping, but in a different way. So each element can be, the denial and coping and other elements can influence the model. So then you would look more, it will look more like the ICD model, that you have the impaired function, the impaired, and then the effects of the environment, the effects on what activities are impaired, integration of that, but the basis would still be first look at the offline, online elements, where is the exact problem, then where does the problem come from, integrated in this manner. But it would be difficult to keep it simple.
Yeah, that's true, because then you all have these cognitive domains and social cognition, which already has been mentioned. But actually you say that you would include both the off and online elements. But in chapter 2 you found out that there was no association, but still?
Not in when you measure it, so you cannot use the measurement for the one to say something about the other, but they do interact with each other in a way. Of course, your prediction on the online task, so before I start a task, my prediction is based on the knowledge that I have on this offline database, and also my experience in the online parts updates the knowledge database. So there is an interaction, so you would still need to keep both of them, I think.
Yes, but do you then want to change the measurement or the concepts?
The measurements, I think. But it's difficult.
Of course, it's really difficult. So it's it's great work that you did, but it's very complex also. Just something else, errorless learning. Well, this is something which is used in rehab centers, which is quite different from the Socrates approach. And how would you deal with this, with all these therapeutic methods who are very focused on this errorless learning, which is actually in contrast with the Socrates learning?
I'm not super familiar with errorless learning, but I think it's that every time you make a mistake, you stop and avoid this, right?
Yeah.
I think in these cases, maybe it might not be the best way, because it's not necessarily you are allowed to make mistakes. That's not the problem here. It's just how you process the mistake and how you reflect on this, how you deal with this if it happens. So for the self-awareness parts, I think the errorless learning might not be the best approach to increase the self-awareness.
No, true, I agree. But all these professionals are very used to errorless learning now. So and you are a believer. So how do you convince these people?
Well, that's an interesting point, because then if you tell people they need to change behavior where they don't see problems with, is basically also the problem with the patients, of course. So it is difficult to change that behavior. But then indeed, if we could prove that it works, which we could not now with the null findings, but if we find more evidence for this, if we have better controlled studies that the difference is, the contrast between the two treatments are big enough that we can actually see that there is an effect, maybe that can help influence their behavior.
Maybe you can use Socrates motivating for your professionals.
Yes, definitely. That would be interesting as well,
to
investigate this.
Well, actually, I would like to return my...
And I think that Professor Kott still had a question remaining.
Well, the question was asked, so... But, I had actually also one of the propositions. I can find my sheet now. Thank you. But I had my... sorry. May I read?
Anneke Terneusen, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room. Anneke Terneusen. The degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Van Heugden is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Thank you, Pro-Rector. I will first ask a question. Belooft u dat u altijd te werk zult gaan volgens de beginselen van wetenschappelijke integriteit? En dat betekent eerlijk, zorgvuldig, transparant, onafhankelijk en verantwoordelijk.
Ja, dat beloof ik.
Krachtens de bevoegdheid ons door de wet toegekend en volgens het besluit van de commissie hier tegenwoordig verklaar ik herbij u, Anneke Terneusen, te bevorderen tot dokter en u alle rechten te verlenen die daaraan door wet en gewoonte zijn verbonden. Ten bewijs hiervan overhandig ik u nu de bul, door rector, secretaris en alle overige leden van de promotiecommissie ondertekend en met het grootzegel van de universiteit bevestigd.
Oh, I will do this in Dutch, sorry. Dr. Terneusen, beste Anneke. Aan mij de eer om nu alle lof over jou uit te spreken. Maar ik doe dat ook namens Caroline en Rudolf. Ten eerste namens ons drieën van harte proficiat met het behalen van deze titel. Deze mooie mijlpaal in je carrière. En ook proficiat aan jouw familie en je naasten. Nou, wij hebben elkaar leren kennen toen je ergens in 2016 naar Maastricht kwam voor je Research Master Cognitive and Clinical Neuroscience met de specialisatie Neuropsychology. In het tweede jaar van die master kreeg je al belangstelling voor het onderwerp ziekteinzicht en ben je voor je afstudeerscriptie, je onderzoekstage, bij ons aan de slag gegaan met het onderwerp ziekteinzicht. En dat heb je niet meer losgelaten. En in 2018 kon je bij het expertisecentrum Hersenletsel Limburg aan de slag als promovendus op het onderwerp. En ik kan zeggen, wat hebben wij met jou geboft? Wij hebben ons nooit zorgen gemaakt dat dat boekje er niet kwam. En dat kwam ook vooral door jouw eigen stoïcijnse houding. Ik denk dat u het allemaal met mij eens bent. Anneke is een coole kikker, hebben we gezien vandaag ook. Maar wij vinden je vooral ook een coole kikker. Altijd rustig, althans voor zover we dat kunnen zien. Of we jou nou vragen om een systematic review te schrijven over imagingstudies naar ziekteinzicht. Of om op het allerlaatste moment een presentatie over te nemen op een internationaal congres. Het is net of je Anneke vraagt om naar de Albert Heijn te gaan voor een boodschap. Dat is geen probleem voor Anneke. Het is je zelfs gelukt om dat paper gepubliceerd te krijgen dat ik al jaren op de plank had liggen. Te publiceren in een mooi internationaal tijdschrift, waarvoor dank nog. Je bent ook altijd zeer zelfstandig aan de slag gegaan. Jij wilde graag een fMRI-studie doen. Dat heb je helemaal zelf geregeld, je helemaal zelf eigen gemaakt. De ingewikkelde statistiek voor je grote RCT heb je zelf uitgezocht, zelf uitgevoerd. En toen we een uitstapje maakten naar metacognitie bij gezonden, ben je zelf in de literatuur gedoken. Ik moet eerlijk zeggen, er zijn momenten geweest als je uitleg gaf over de statistiek of de MRI-data, dat ik dacht, het zal wel kloppen. Anneke is ook iemand van weinig woorden. Toch in ieder geval tijdens de regelmatige teamoverleggen die wij met z'n vieren hadden. Ik weet niet of u dat herkent. En Rudolf vond je eigenlijk maar een beetje vreemde Brabander wat dat betreft. En het duurde altijd even voordat wij als team wisten waar je woonde en met wie je daar woonde. Wie Jasper was en dat Jasper heette. Maar we hebben je toch steeds beter leren kennen. En ik weet nu dat je niet alleen een geweldige onderzoeker bent, een hele fijne collega, maar dat je tussendoor ook nog tijd hebt om de wereld te zien, om halve marathons te rennen en om een voorvechter te zijn van gelijke rechten voor iedereen. En daar horen ook dieren en ongeboren kuikens bij. Anneke, ik heb bewondering voor hoe je in het leven staat. Nou, tegenwoordig ben je bij onze buren aan de slag als onderzoekscoördinator, waar je je carrière voortzet op het gebied van de ziekte van Parkinson. Ja, super en dik verdiend dat je direct na afronden van je promotie bij deze universiteit verder aan de slag kon. Ze hebben ongetwijfeld een hele goeie aan jou. Stiekem hoop ik dat we in de toekomst nog eens samen aan de slag kunnen. Ik spreek ook denk ik namens Carolien en Rudolf. Je bent van harte welkom om alsnog verder te gaan bij ons of terug te komen naar ons. Er liggen nog meer dan genoeg vragen met betrekking tot ziekteinzicht en metacognitie. Voor nu van harte proficiat. We wensen je vandaag een mooie avond toe, morgen een mooi feest. En dan wil ik afsluiten met jouw eigen woorden. Anneke, je bent een goeike.
Dear Dr. Terneusen, on behalf of the department, which most people are here, of the Faculty of Psychology and Neuroscience, and of course also the University of Maastricht, I would like to congratulate you with this fantastic achievement, being a doctor now. I would like to, with this said, I would like to close this meeting. Having closed this meeting, you can also rest. We will stay here for some photos with the online people. On the right, where you can get a drink or something else, if that's allowed. Yeah, it's allowed. And then we can meet there, and then you congratulate the candidate or Dr. Terneusen in the rafter.